Hello and welcome to this episode of On Geriatrics. Today we shall be talking about the problem of low sodium. In medical parlance, it's called hyponatremia. Now, why is hyponatremia important? The elderly particularly are prone to hyponatremia. It is a very complex topic, and even medical professionals are often confused about the causes and how to manage hyponatremia. So I will not delve into the complexities of hyponatremia, but what I will share are a few basic things about hyponatremia or low sodium that the lay public, the elderly as well as their caregivers must be aware. First of all, why is low sodium so important? So before I go into that, let me differentiate hyponatremia into two categories from the clinical standpoint. One is acute hyponatremia and the other is chronic hyponatremia. Acute hyponatremia refers to low sodium developing in the recent past, that is over a few hours or days. So there is a sudden change in the level of sodium in the blood. This is acute hyponatremia. The other is chronic hyponatremia, where there's been a low sodium level for a very long time, over days, weeks, or months, and even years. So these two have to be dealt with differently. So what happens in acute hyponatremia? The sodium level drops in the blood, and the most important effects of this is on our brain. When the sodium level drops in the blood, there is a difference in osmolality between the fluid outside the brain cell and inside the brain cell. So what happens when sodium level drops in the blood? Water from outside the brain cells move into the brain cells to equalize the sodium level or the osmolality inside the brain cell versus outside the brain cell. So when water rushes into the brain cell swells. When all the brain cell swells, the brain itself swells, and you know that the brain is contained in a hard casing called the skull, which is a bone. And the brain cannot expand within this hard casing, so it gets compressed, and sometimes it can herniate through membranes that separate different chambers of the brain, and all this can cause severe damage to the brain and its functioning. That is why when there is a sudden change in sodium level in the blood, the main manifestation is that the person develops confusion, and if it is not mitigated, this confusion can even go on to become more severe in the form of fits or convulsions, or the person may go into coma, or it can even lead to death. And that is why a sudden change in the sodium level or an acute hyponatremia addressed as early as possible and as judiciously as possible, which I'll come to in a little while. What is chronic hyponatremia? Low sodium is prevailing over a long time. Here what has happened is slowly the osmolality between the brain cell as well as outside of the brain cell has established an equilibrium. So there is no net movement of water into or outside of the brain cell, and so there is no sudden swelling or shrinkage of the brain cells, and so there is no emergency. But this low level of sodium can affect brain function and should be treated and corrected, but not with the same degree of urgency as we do with acute hyponatremia. You know, why I'm emphasizing this point is that rapid correction of sodium levels is also dangerous. And that is why we need to distinguish whether a rapid correction is required or not before we rush into correcting. So what happens if we try to correct the sodium levels rapidly? The opposite effects. The sodium level in the blood goes up, and because of that, water from within the brain cells start moving out, and this can cause shrinkage of the brain cells. Sudden shrinkage of the brain cells is equally harmful and can cause permanent damage, and it can lead to conditions like permanent paralysis, locked-in syndrome, where the person cannot swallow or express himself, or conditions which are psychiatric in nature, so abnormal behavior which can be permanent can result. So that is why it is very important to be very careful while correcting sodium. Even in acute hyponatremia, the rate of correction should never exceed more than 8 milliequivalents per liter in a window period of 24 hours. And that also has to be done slowly as per the doctor's advice. So what causes hyponatremia? As we age, our physiology changes in such a way that there tends to be a little bit more of antidiuretic hormone, ADH, which what it does, antidiuretic hormone, it conserves water. So when water is conserved, it will dilute the sodium level in the blood. So there is a tendency, not everybody as we become old become hyponatremic, but there is a tendency as we age towards water conservation, which makes us more prone, which makes the elderly more prone for hyponatremia. And then what precipitates hyponatremia? Usually, of course, there are very many causes for hyponatremia, but by far the commonest causes for hyponatremia is one, an infection, and the infection can be either respiratory or sometimes even urinary tract infection or diarrheas, which are the three most common sites of infection, apart from other infections. And the other is a medication which has been introduced, or a medication which the older person is taking, which also can predispose the person or which can precipitate hyponatremia. Then there are conditions like a sudden stroke or other form of insults or diabetes going out of control, etc., which can commonly precipitate hyponatremia. There are very many other rarer causes like kidney disease, etc. We'll not go into all that at this time. Sometimes excessive water intake. A person is drinking a lot of water, or people who are drinking a lot of beer, for example, can also this can also result in hyponatremia. Let me name a few common medications which can precipitate hyponatremia. One is a class of drugs called antidepressants. Elderly are often depressed and are put on antidepressants, and one must remember that can precipitate hyponatremia, and therefore when one is starting on antidepressants, one should be on the guard for the initial 1 to 2 weeks to see if there is any sudden development of confusion or other symptoms related to hyponatremia. antipsychotics, then anti-epileptic medications, then certain antihypertensives, especially the diuretic variety like thiazides, hydrochlorothiazide, which is commonly used, can precipitate hyponatremia. Rarely antibiotics, some antibiotics, and some anti-cancer drugs, to name some of the more common drugs which cause hyponatremia. The list is much longer, but let us not go into that at this moment. How do we manage hyponatremia? How do we approach? As I said, acute hyponatremia is a medical emergency and has to be managed as an emergency. And the usual way is to bring up the sodium level through infusions of sodium, which is available as either 3% solution or normal saline solution, which is 0.9%, depending on what is needed, what the doctor decides. But the important thing to remember is not more than 8 milliequivalents should be corrected in 24 hours, and that too at a specified low rate. And of course, whatever has precipitated the problem, that has to be addressed. That is, if there is an infection, the infection has to be treated. If there has been an offending drug or a medication that has been recently started, that has to be withheld. And very important, restrict fluids, because this is hyponatremia is a problem of water retention, excess water, not low salt. It is more water. So restrict the fluid intake of the person. Sometimes the doctor may advise you to restrict it to 1 liter per day. And that will automatically help in bringing up the sodium. Why not give more salt, you may ask? Giving more salt is fraught with many risks. It can worsen hypertension or precipitate severe hypertension. It can precipitate cardiac failure. So giving more salt is the last resort when all else fails, and should not be the first intervention. Chronic hyponatremia, as I said, it is not an emergency, and it will suffice if we restrict fluids, treat any underlying causes like infection or medications, etc. And usually we will be able to bring up the sodium levels to a level where the brain functions properly. Let me also mention about a medication called tolvaptan. Now tolvaptan, what it does is it blocks the effect of ADH, which conserves water. So it helps in throwing out more water from the system and bringing up the concentration of sodium. But this has to be used judiciously. The patient has to be well hydrated and probably should not be used on a continuous or a long-term basis, and one should follow the doctor's advice on this. And always remember, having a loved one close to the patient helps in mitigating a lot of problems. Remember to keep a loved one close to the patient. Goodbye for now.